Good afternoon, everyone. My name is Elizabeth Olson. I'm with the California Prevention Training Center. Can you all please raise your hands if you can hear me or put a little note in the chat box? Okay, great. Well, welcome everyone. Welcome to our STD Expert Hour webinar series. Today, we are going to be speaking about delivering sexual health services in the time of COVID-19. We have our two faculty members here today that you can see here on the camera with us. First, I'd like to introduce Dr. Ina Park. Dr. Park is the medical director for the California Prevention Training Center. She's an associate professor in the Department of Family and Community Medicine at UCSF, as well as a consultant for the Center for Disease Control and Prevention in the Division of STD Prevention. She also cares for patients at the San Francisco City Clinic. Dr. Park was a co-author of the upcoming 2020 CDC STD treatment guidelines, and she's also the author of a forthcoming book on the hidden role of STDs in our lives and society. It's titled Strange Bedfellows: Adventures in Science and History and Surprising Secrets of STDs. It's going to be published by Macmillan in February of 2021. We also have with us today Dr. Rosalyn Plotzker. She is also clinical faculty at the California Prevention Training Center. She's an assistant professor in the Department of Epidemiology and Biostatistics at UCSF. She is also a public health medical officer at the California Department of Public Health and STD controls. So we want to go over a few housekeeping items today for you attendees. Your attendee screen, next slide, please. And next slide. First, I'd like to show you this attendee screen. On the left, you see your slide view, and on the right, you have your control panel. Next slide. You will see an orange button on the left that has a white arrow, and you will use that to minimize or control your control panel. Below that, there is a white arrow to expand the questions box. You can also undock the questions box, which means to just pull it out entirely so you're only looking at it. There is a white box on the right with an arrow line through it that says dock and undock, and that will separate out the questions box. Next slide, please. For your audio, you all are muted today with the exception of staff and faculty. If you do have questions, again, we encourage you to put them in the chat box. You're going to have two options for your audio. You can dial in with your computer, but if at any time you have issues here, you can also select the option for a phone call. And once you select that option, it will give you a phone number so you can dial in and listen. Again, we encourage you to submit questions. We are going to collect questions throughout the end and present them to our speakers at the end of this presentation, and we'll be collecting them as we go along, but we will not be answering them as they come up. So please be patient on that. I also want to go a little bit over the California Prevention Training Center in case you are new with us today. We are a national training center that delivers innovative training and capacity building assistance to both public and private healthcare providers. We are funded by the CDC to provide collaborative services for a wide spectrum of medical, health promotion, and community professionals who are serving people and communities impacted by HIV and STD. Next slide, please. We are also part of the national network of prevention training centers. There are several prevention training centers throughout the country doing similar work as we do. Our service area includes California, Nevada, New Mexico, Arizona, and Hawaii. For the CME today, the CME is approved for 1 credit for your full participation today. In order to get your CME, you are going to have to register on the NMPTC site if you have not already. That is to say, if you receive this link from a friend and just went straight to this GoToWebinar and you're not registered on our other site, you are going to have to go ahead and do that. We will put the link for that, and you can also email me. We will open up late registration as it's closed now. But to qualify for that CME, you first need to be on the NMPTC site, and you also need to complete an evaluation. This evaluation is going to go to the email that you used to register on the NMPTC. Please do look in your junk mail folder, as that evaluation frequently goes there. You have 10 days to complete that evaluation, and we also ask you provide your license number. And after you've done those steps, you will receive an email going directly to your continuing education certificate that you can download. Next slide, please. We would like to let you know that our presenters and planners do not have any conflict of interest, financial or otherwise, in this presentation today. Next slide. If you have any questions, and again, please take note of this email address if you did not register on NMPTC already. But if you have any questions after this presentation, please go ahead and email me. And so with that, I'm going to hand it over to Dr. Park and Dr. Plotzker, and they're going to turn off their webcams so you guys get a bigger screen, but we wanted to make sure they're able to wave hello to you. Thank you all for joining us today.
Thank you, Elizabeth. Hello and goodbye. We're going to turn off our cameras. And then let me advance the slides. So yes, you are, hopefully you're at the right webinar, delivering sexual health services in the time of COVID-19. And again, we have nothing to disclose. And so we're going to start with a brief poll, and Elizabeth hopefully will launch the poll. And the question is, how is your clinic delivering services right now? Number 1, are you doing most clinical encounters in person? Number 2, are you doing sort of half and half telehealth in-person services? Number 3, would you say you're doing most of your clinical encounters over telemedicine? Or number 4, are you guys completely shut down and not actually offering services? Or number 5, maybe it's not applicable to you because you don't work in a clinical setting.
Okay, it looks like it's about half and half of telehealth and in-person services, with the remainder about 25% in-person and 20% telemedicine.
Okay, that's really interesting because I've now given this talk. This is the 3rd time in different forms or another, and we certainly have seen an evolution of folks who are offering at least some of their services via telehealth. And that makes a lot of sense given what's going on. And let me advance. So I'm going to start off by just pointing you out to a resource, since we are talking about delivering sexual health services, and that certainly does include treatment for sexually transmitted infections. Just so you know, the CDC did issue interim guidelines for how to treat people based on syndromes. So, you know, penile discharge, vaginal discharge, someone presenting with a genital ulcer. In case you may not have an opportunity to do a full workup, diagnostic workup and physical exam, there's some guidelines for treating presumptively, and we're going to talk a little bit more about what that means. And there's a link there is a link on the slide, and you're going to be receiving that, of course, as well when you receive the slide deck after this. Roz?
Yeah, so this is also a sample template, and basically this is just kind of to outline who is a good candidate to be seen by telemedicine, who needs to be seen in person and how urgently, and also what can be postponed or just taken care of with a quick phone call. So just to walk you through this a little bit, you know, things that can be postponed are basically your routine care, meaning routine STI screening, pap smears. A lot of colposcopy can also be deferred, as well as 2nd and 3rd doses for HPV vaccine. So all of those can be postponed for now. For birth control methods, those can be refilled just with a simple phone call, so that is a pretty easy one to take care of. In terms of telemedicine, the types of things that you can handle via telemedicine, either over the phone or with video, would include contraceptive counseling, as well as counseling for DMPA sub-Q, which includes instructions for patients who are opting to do the self-injection for that. We'll talk about this in depth, but syndromic treatment of STIs and for UTIs is also something that's reasonable to do over the phone. And you can also do PEP and PrEP intake over the phone. The labs you do still need to do in person, but the intake itself you can do via telemedicine. In terms of the in-person things, which are in orange, the ones that are less acute and can just be scheduled as available are patients who would either need their IUD or implant either placed or removed, as well as DMPA intramuscular injections. And so those are typically done either at the clinic or via curbside. However, those are less urgent, and so those can be done just as a scheduled appointment as they are available. The things that are the most acute and should really have the patient seen in a day are things that are symptomatic, including rectal pain or bleeding and purulent discharge that is rectal. And then vaginally, if you have non-menstrual bleeding or pain, which could be either PID or an IUD complication, those also need to be seen the same day. And then finally, sexual assault is something that needs to be evaluated immediately. So those patients should all be seen right away in person.
And Roz, one thing I wanted to add was that we're going to talk a little bit about how people have done some work around the in-person labs for PrEP intakes a little bit later on in the presentation.
Yep.
Okay, let me advance the slides.
So Ina, I mentioned syndromic treatment. How would you define syndromic treatment and explain it?
So syndromic management is something I think many of us are not comfortable with because, we like to know what we're treating, but this would be, treating based on the best guess of what you think the patient has and without the use of laboratory tests. And this certainly happens quite a bit in the developing world. And of course it happens for us as well when we have patients who walk in who clearly need something that day and we don't know exactly what they have. And this approach works pretty well for penile, urethral, chlamydia, and gonorrhea. It works okay for BV, especially if you also have the assistance of pH paper to help. It can work for candida vaginitis if the patient has, classic symptoms and classic appearing discharge. For genital herpes, it's really plus or minus. Some studies have, shown actually pretty good concordance with laboratory diagnosis, and then others have shown that it's terrible. So it's really hard to say, but I can tell you it's not great when someone comes in with vaginal discharge. The predictive value of sort of being able to diagnose gonorrhea and chlamydia is pretty poor. And the issue is that, as you know, when someone comes in with non-specific discharge, could be any number of things, and so there's many false positives possible, and you can overtreat folks and you can get the diagnosis wrong. But we are dealing with this to a certain extent in the time of COVID-19. And so Roz, I mentioned about vaginal discharge being challenging, and so how are people evaluating folks with vaginal discharge remotely, and is that even possible?
Yeah, no, it's definitely possible. And, a lot of it, like you said, is similar to what we would do in clinic that we can do over the phone, with the exception that we can't actually evaluate it ourselves. But we can talk to patients and try and gauge based on the characteristics of the discharge what might be going on. So for patients who, have had BV or have had yeast infections in the past, and they get them every couple months and they recognize them, then one of the things that you can do over the phone is just talk with them about the symptoms, and they can tell you, this feels a lot like when I had a yeast infection a couple months ago, or I get BV every now and then. And I think that given this setting and this situation, it's reasonable to do treatment based on a recurrence of BV or a recurrence of vaginal candidiasis if it's recognized by the patient. That said, for a patient who has a new problem, they have some vaginal discharge that they don't recognize or don't associate with a previous experience, that you would need to have a more thorough history and then figure out which empiric treatment would be appropriate. So, and you'll see this in a chart coming up, but basically if you have a patient who has malodorous discharge and that is suggestive of either BV or trichomonas, then you can treat that with metronidazole, and that's 500 milligrams BID for a week, and that will treat either BV or trichomonas. And if you have somebody who is describing something that's more irritated and itching and the discharge is white, typical of a yeast infection, that you could treat with either fluconazole, 150 milligrams PO, or you can do the 3-day topical antifungal treatment. And that would be just treating for a yeast infection. In terms of sampling, this obviously, if we're doing this over the phone, we're not able to do pelvic exams, so we can't really appreciate the odor ourselves, and we can't do wet mounts right there. However, some clinics are using a curbside strategy for doing pickup and drop off for vaginal discharge, and so they basically have these kits. And what the kit contains is a stoppered plastic or glass tube, and that has about a cc of fresh saline in it. And then it also contains a sterile swab that's a cotton swab. And so these patients can pick up the kit and then they can go do a home swab where they basically self-swab the vaginal walls and then put the swab into the tube and then cap the tube and bring it back to the clinic. And they want to bring it back as soon as possible so that it's a fresh sample, and then it could be evaluated with microscopy by the clinicians in clinic if they have access to that. So that is one option. And then you could, find out if there are clue cells, if there's yeast, if you see trick, and that can help have a more specific diagnosis. And this can also be used if you want somebody to do a self-swab for a GCCT NAT, and that would, of course, require that the patient use the appropriate specimen collection kit, but that's also an option. Next slide.
Yeah, and can I just mention something really quick?
Yeah, of course.
The last time we gave this talk, I don't know, folks have asked about, well, what if the patient drove up or someone drove them and could they just collect in their car and then immediately give it back? And I said, absolutely, I think that would be fine.
Yeah, or if they don't want to do it in their car, but there's a restroom nearby, they can go do it there, that's fine too. Yeah. And so this is probably going to remind a lot of you of when you were in training, where we have all these different vaginitis findings, and then the quality of the discharge. So for Candida, there is itching, sometimes there's burning, I is itching, B is burning, usually neither odorous nor frothy, usually white. So that's a typical yeast infection. Trichomonas, you would have itching, usually not burning, and then you would have odor and you would have a sort of frothy quality, and it can be yellow, sometimes white, so not as specific. For BV, usually the patient does not report itching or burning, but they do have that characteristic odor, and it's frothy and can be considered kind of looking like homogenized milk or white. Desquamative inflammatory vaginitis, which is a rarer finding, is a rarer condition, can be uncomfortable, it can be itching and burning, usually neither malodorous nor frothy, and what you'll see is profuse discharge, that's either green or white. And then, physiologic normal discharge, not itchy, not burny, and is usually just white, normal discharge. So stepping away from yeast and BV, should clients, Ina, be treated for GCCT if there's vaginal discharge? And then also, what about penile discharge?
Yeah, so Roz, there was a lot of discussion at CDC about this, about whether or not empiric treatment for GCCT should be recommended. And right now, they because just discharge, even if you know the characteristics of the discharge, predicting GCCT is very hard. So the guidelines do not recommend empiric treatment for GCCT when patients have vaginal discharge. And so, you know, again, as you mentioned before, test for GCCT before treatment. And then, of course, the exception would be if the patient is a known contact, then you'd be treating empirically anyway. But when we get to penile discharge, the CDC guidelines do recommend empiric treatment. And of course, we know that, you know, penile discharge could be gonorrhea, chlamydia, it could just be NGU, mycoplasma, it could be a lot of things. And what they recommend right now is if you're able to do an in-person evaluation, use your standard ceftriaxone. And then they actually recommend using doxycycline twice a day for 7 days in case chlamydia is there, because the efficacy against chlamydia is a little bit better with doxy. There's been several studies since the last treatment guidelines that have shown that. Well, so if you can't see a person for IM treatment in person, then the recommendation is to actually treat with cefixime 800 milligrams. People on this webinar are going to notice that's twice as much as is normally recommended for PO medication. Just so folks know, you know, there's a tendency towards using more cephalosporins for presumptive GC treatment. You'll see probably some changes in the forthcoming treatment guidelines. And so in the interim, they doubled the cefixime dose and also added doxy to cover chlamydia. And so, you know, we mentioned that folks with vaginal discharge might be able to be presumptively treated for some things and tested then for gonorrhea and chlamydia, but what if the client is having pelvic pain or dyspareunia? Is that something that you think is, you know, can ever be evaluated via telemedicine?
So like I mentioned in the first table that we talked about, or I guess technically the second table, where, you know, who needs to be seen in person. If somebody has pain, that patient could have PID. And so for this, you do need to evaluate them in person. So you would need to refer them to have a pelvic exam and be seen in person. And we do not recommend treating that empirically. And so, yeah, I think that's the one situation of vaginal discharge that you absolutely need a pelvic exam.
Yep, and I think, so I'm attending this telemedicine learning series from the Department of Health and Human Services, and they, you know, universally agree that any abdominal pain pretty much just needs to be seen in person, whether it's whether it's in a male, female, or you know, regardless of gender.
Yeah. Okay, so stepping away from discharge for a minute, how can a client with vulvar irritation or a rash be evaluated remotely?
Okay, so we have some good options here. You know, when you have folks who obviously have a history of recurrent genital herpes, you know, those are folks treated empirically, and we often just do refills, you know, over the phone or call in refills for acyclovir or valacyclovir. For rashes, you know, there's a lot of precedent with this with teledermatology, and you know, we would recommend, or what is recommended, I guess, is submitting, you know, a cell phone photograph of the genital skin rash. There is a billing code here. It can be covered as a virtual check-in. The billing code is provided here, and you know, essentially that covers the remote evaluation of either video from the patient or images, including interpretation within 24 business hours. So, you know, there is precedent for this. Teledermatology has been, you know, going on for quite a long time, and so that is continuing, and even more so during the pandemic. And just so you know, in terms of what protections are in place for folks who are practicing this way, you know, HHS, Office of Civil Rights, issued a statement back in March, which is still true. I went back and made sure that they haven't updated this, that, you know, a lot of people in the beginning, especially, were using these non-HIPAA compliant platforms, and that HHS said that they would not impose penalties for HIPAA violations, you know, if folks are trying to, in good faith, giving provision of telehealth services during this time. And so folks have basically deliver telehealth, via Apple FaceTime, Google Hangouts, Zoom, and WhatsApp, which is obviously allowing for, live chatting. And then of course, like, texting, pictures to providers, business phones or personal phones. That has happened. What is not acceptable would be doing any sort of patient interaction on a public facing platform. And so if you want to read the HHS regulations on telehealth, there's an FAQ page, which is linked there. Okay, so, staying on the topic of teledermatology, what about if clients have genital or anal ulcers, Roz?
So like you mentioned, recurrent genital herpes you can treat empirically. So we would call in a refill, and you can talk with the patient on the phone and just confirm this is in the same place where they usually get herpes. This feels exactly the way it feels when you get herpes. So for patients who have recurrent herpes, you can treat that. Oh, can you go back?
Yes, I'm sorry.
That's okay. For a new ulcer, that in-person exam is best, but if that's not possible, then the main thing that you want to think about is if the ulcer is painful or not. And that's because a painful ulcer versus a non-painful ulcer is one of the key things that can help you differentiate herpes from a syphilitic ulcer. If you have a photograph of the ulcer, then it's always helpful to see it. But in terms of pain, patients presenting with painful ulcers, especially ones where there's multiple, and especially if they're bilaterally, then those are more likely to be genital herpes. Meanwhile, ulcers that are painless, and especially if there's just one, although sometimes syphilis can present with more than one primary ulcer, but if there's a single painless ulcer, that is more likely to be a primary syphilis chancre. Next slide. So if you do think it's syphilis, then you want to arrange to have a serologic test for syphilis to monitor the treatment response. So that would be your non-TREP test, which would be the RPR, and that's the titer that you use to see how the person responds to treatment. So that would be your baseline titer. For primary syphilis, if the patient is not able to get the benzathine penicillin IM injection, which is the first line of treatment, then the alternative would be to give them doxycycline, 100 milligrams twice a day for 2 weeks. The exception to that is, of course, pregnant patients. And so if you have a pregnant patient who has suspected syphilis, then they absolutely need to have IM therapy, even if they have a reported penicillin allergy. Penicillin is really the only treatment, and they would need to be desensitized if there was an allergy. So that's the exception, but doxycycline is an option for non-pregnant patients who have syphilis.
And Roz, would you agree that if you strongly suspect syphilis based on like a really classic appearance, just go ahead and treat empirically before their serology is back?
Yeah, absolutely. I think that probably a safe way to go would be to bring them in, and when they have their treatment, also draw their blood, and that way you have a day of treatment titer, which is ideal in terms of looking at treatment response. One of the tricky things people fall into is that they have the blood drawn, and then the patient isn't able to get treated for another couple weeks, and so you don't really know what their titer was on the day of treatment, and that complicates interpreting decline. And also, if you do have them come in and you're able to, doing a thorough neurologic examination is always recommended for people with syphilis.
And even if you get that titer when they first come in, if they had a genital ulcer, it still might be negative, because 20 to 30% of the time in primary syphilis, the RPR might be negative, but you still might have been right.
Yep.
The diagnosis.
Yep. Okay, so how should providers manage rectal symptoms? I think we might be coming back to discharge. So we might be coming back to discharge and thinking about rectally,
Yep.
especially if you're thinking about GC and CT.
Yeah, so rectal symptoms, obviously, ideally an in-person exam and testing for gonorrhea and chlamydia if you're suspecting proctitis, is ideal. But one thing to mention is we know SARS-CoV-2 can be found in the stool. And so it is also reasonable to do presumptive treatment for proctitis and have the patient actually self-collect a swab for GCCT. And I also included a link on this slide, which you guys will also get, that has 8.5 by 11 self-collection posters that are translated into Spanish and English. So if you need to put those up in your clinic because you want patients to self-collect. But at any rate, you guys are going to recognize these. The empiric treatment, for something like proctitis-like syndrome would be to treat, again, with cefixime 800 milligrams, so double the dose that's usually recommended, plus doxycycline 100 milligrams for 7 days. And again, that'll cover GC and will also cover chlamydia if it's present. And then, of course, if the patient is pregnant or doxycycline is not available, then you can also use Zithro as your second drug.
And what about the throat, since we're talking about extragenital infections?
Yeah, so most of the time sore throats are not gonorrhea and chlamydia, but some other considerations is that we also know pharyngeal sampling can cause patients to gag and cough. And so again, self-collection would be recommended and would minimize risk to the clinician. So here's another link for bilingual self-collection posters that you might be able to use. And so you could do empiric treatment, but symptomatic pharyngitis is so much more likely to be caused by non-sexually transmitted bacteria and viruses. Could also be a symptom of SARS-CoV-2. And so just a sore throat is not something that we would typically just treat empirically. Of course, if the person's a contact, that's another story. Okay, Roz, we've been talking about this quite a bit, you and I. Is there such a thing as safer sex when it comes to transmission of SARS-CoV-2, and what advice could we possibly give to patients around this?
Yes, this is the thing that I get asked about a lot. And the thing is that I want to preface everything I'm saying with the statement that sex is physically if you are having sex with another person and they are with you in the room, that sex is usually a very, very physically intimate activity. And so the likelihood of you being within 6 feet of each other and exchanging, respiratory droplets is probably going to be pretty high regardless. So I think that one of the things to keep in mind, and I'll talk about this in this list of safer sex tips, is just that, some people try wearing masks or try wearing, I'm not going to advise putting a donning and doffing station in the corner of your bedroom. Like, I think that you just have to keep in mind the fact that the people who you have sex with you are most likely going to be transmitting droplets with. And that there is not a lot of good research about the efficacy of using masks or adjusting your sexual position so that you're not facing each other. Even though those things have been recommended, there's not a lot of scientific evidence about that. So it's something that some people are trying. But all that said, obviously, masturbation, using sex toys, you cannot get SARS-CoV-2 if you are alone. And the same with video or sexting, virtual sex, same thing. One thing that some people have been doing, which is I think is a reasonable approach, is to have selective kissing or selective sex partners. So basically having a specific group of people or specific individual who is your sex partner or are your sex partners, and having very, very clear communication about that and about what their risks are for SARS-CoV-2, what your risks are for SARS-CoV-2, and figuring out who your close contacts are. So that's the basic stuff. In terms of barrier methods, like Ina said, or Ina, like you said, the main concern is about oral anal contact, and that's because there have been studies that have found SARS-CoV-2 in stool. So ideally, you would avoid oral anal contact, or you would use a barrier method if you are doing oral anal sex, and you would use the barrier method to minimize the exposure and risk of transmission. And then also, washing your hands before and after sex is a good practice. And also I just want to say the sex in the time of COVID-19, this is something that came from Oregon's End HIV group, and it's based on some guidelines that have been put out by New York City. So, you'll find things like this floating around online coming from different places. One place is Canada. Next slide. So this is a statement that came out from the Canadian CDC, which has been getting a lot of attention in the media, and it mentioned glory holes, so using barriers like walls that would allow for sexual contact but prevent close face-to-face contact. So this has been around social media a lot, and so I thought it was worth mentioning. I don't think you need to do major construction on your house in order to comply with this, but that was something that got mentioned, and so I thought it was worth bringing up.
Yeah, it's certainly happening based on my conversations with patients that glory holes are coming back, public, sort of glory holes are coming back up again, and it would be hard to contract SARS-CoV-2 from behind a barrier, with just a whole penis.
Yep.
And so, why don't you share a little bit, Roz, the data that we do have about sexual transmission of SARS-CoV-2 and where the virus is actually found in terms of vaginal and semen?
Yeah, definitely. And when we think about sexually transmitted diseases, we typically think of pathogens, meaning viruses, bacteria, parasites that are found in sexual fluids. And so SARS-CoV-2 has been detected in semen. However, it was semen of men who had an acute infection, meaning recent, and that they were recovering. So that's where they have found SARS-CoV-2. So if it's somebody who is asymptomatic and unknown, and if they had a negative COVID-19 test, but then coincidentally they found it in semen, that hasn't been found. In terms of if it can be transmitted, if there's a cis man who has SARS-CoV-2 in the semen and then has condomless sex with someone, it's not really known if the virus can then be transmitted sexually in that way. So, respiratory droplets and saliva are exchanged during sex, and that is more likely to transmit the virus independently of semen. And then in smaller studies, and these are studies that were done in China among cis women who had severe COVID-19, they sampled vaginal fluid and they did not find SARS-CoV-2 in the vaginal fluid. All right, so moving on, how can providers use EPT or expedited partner therapy for gonorrhea or chlamydia treatments?
So I think I don't know if everybody on this webinar is familiar with expedited partner therapy for gonorrhea and chlamydia. It's also used, at least in the state of California, also allowable for trichomonas. But typically EPT would be done by writing a prescription in the name of the partner or doubling the dose of the patient's medications, and then instructing the patient to give a dose to their partner. And I think really this is a critical service during this time to avoid the need for clients who might be being seen in a face-to-face visit, but certainly partners, a face-to-face visit could be avoided by the provision of EPT. But one thing around the CDC's guidance around this is that they only ever recommended EPT for cis heterosexual men and women. And in their interim guidelines, they did not specify so specifically who needs to use EPT. And so I would just say that as a harm reduction strategy, I think it could be used for cis men who have sex with men as well as transgender clients, to avoid a face-to-face visit at this point. Whether or not this is a good strategy long-term is another question, but during this time, I think using EPT liberally is probably a good idea. The concern with MSM and transgender folks is that, might you be missing HIV infection, et cetera. But at least from an STD control standpoint, EPT is a good idea. So let's shift gears a little bit, and we're going to give lots of examples here about what people are doing and when you consider delivering PrEP via telemedicine, Roz.
Yeah, so there are many. We have 4 examples. So the good news is that PrEP for telehealth has actually already been established in multiple states prior to COVID-19. So a lot of things already existed, which is great because we have models. So Please Prep Me is one example, and I'll show you that on the next slide. But basically what happens is you can do enrollment and follow-up interviews for asymptomatic patients over the phone with a provider and a PrEP navigator. And then the PrEP-related phlebotomy obviously has to be done in person, but that can be done at a lab, at a draw station, or if the clinic is operating, you can actually have people come in specifically for their blood draws. Please Prep Me is an online platform. So this is one way you can go to the website, but basically it's a telemedicine service that allows PrEP prescription via telemedicine, and these are a couple telemedicine providers. So you have Mr. and Sister, New RX, PlushCare, and there's this, I'm having a little trouble reading it because it's kind of small on my screen, but it's virtual PrEP for adolescents and young adults. So these are just some examples from pleaseprepme.org.
Just to point out, Roz, that so pleaseprepme.org has sort of gathered all of the people who are doing the work in this space, and will on their landing page will show you the sort of pros and cons and different considerations for each of these online providers. So they're kind of linking folks to the online providers of PrEP.
Yeah, they're not doing the they're not the providers themselves. Yeah, thank you for mentioning that point. Then there's usually what would happen is you would get your routine gonorrhea and chlamydia screening for asymptomatic patients, and that would either be done at home with self-swabbing, or it would also happen at the commercial lab stations. The one caveat to that is that whether or not that lab does rectal or pharyngeal testing is not consistent. So there are some labs that do not do rectal pharyngeal testing. So that's one component. Some teleprep providers will mail the medication. Others will fax the prescription to a local pharmacy. And then if there's a patient who develops STI symptoms, for this kind of patient who is on PrEP, I would bring them in rather than do syndromic surveillance. And one of the reasons is because then when they come in, you can assess them for HIV signs and symptoms as well and do an HIV test. And so that's a benefit of having PrEP patients specifically come in rather than do syndromic treatment. Okay, so just to go through a couple examples. This one is from St. Louis. This is a mixed telehealth in-person approach. So in this situation, the patient who's interested in PrEP would be proactive and call the clinic. And then the PrEP counselor talks with them over the phone or the video. They're usually either a provider or a navigator. And if they're eligible, then the patient would come to clinic and would come to clinic only for their labs. And so they would get their HIV, their Hep B, their creatinine, they would get their serology there, and then they would self-collect their STI. Like Ina mentioned, that decreases the risk of the provider being exposed to COVID-19, so the patient isn't accidentally coughing or there's potential for rectal exposure. So then the provider would complete the paperwork for the pharmacy, and then in terms of follow-up, this is assuming that all of the tests come back and the patient is able to enroll. Then the provider does the paperwork for the pharmacy, and from there, if there's no in-person service available for follow-up, then the patient can actually do oral HIV instead of serology. However, the STI testing and the creatinine does need to be done, and that can be spaced out every 6 months. So that's what they're doing in St. Louis. Next slide. I think we're going south to Louisiana next.
Mm-hmm.
Yeah. Okay, so Louisiana has a program that is through Louisiana Health Hub. This was developed before COVID-19 to address rural patients who don't have access to a PrEP provider. And so what happens there is that these patients are referred. They're referred by the parish, which is a county, to the teleprep program. Then the PrEP counselor does the counseling via video or phone, just like St. Louis. They also check insurance status. Then and this is all via lab, so there is no specific clinic in this program. So they check the insurance status, and then the patient is referred to the lab for serology and urine. There's no 3-site testing available. Oh, excuse me. Well, there's no extragenital screening available. They do urine for GCCT. And then there are also some areas where if a patient is in a rural area and the lab is far away, they do have an option for mobile labs, where the labs go to a place that's in a rural area and the patient can then go there. So that's one thing that they've implemented, which is pretty interesting. Then when the lab results are back, if they're okay, then the program has an in-house pharmacy and that mails the prescription out. And then the follow-up is a similar lab process to what they did with initiation. Okay. And then finally, the last example is in Baltimore. And so Baltimore had a pretty interesting approach where, and this is just an alternative for follow-up that is pretty interesting. So we wanted to mention it, where when a patient is due for a PrEP follow-up visit, you can use a telehealth visit in which the provider orders the labs, and then they have worked out an arrangement with LabCorp specific to their region with their LabCorp representative, where LabCorp will mail STD kits to the patient. And then what the patient does is the patient does self-swabs, and I think it includes urine as well. So the patient collects all of the specimens themselves and then drops them off at drops off the STD tests at the lab where they get their phlebotomy done. And then they get their HIV test plus the creatinine if it's due. And then when the labs are back, then the PrEP prescription is sent via the electronic medical record. So that's another option for follow-up. Next slide. All right, so, speaking of testing at home, Ina, do you think that providers can use these at-home test kits for routine STIs?
Certainly, and there's lots of commercial brokers who are offering this. And so some at-home STI screening kits, oh, excuse me, I just advanced my own slide, are, sort of point of care tests with immediate results or self-sampling then with specimens mailed to a commercial lab, which is the more common way to do it. And I'm going to show you a sort of clearinghouse for where all the different places where consumers can get these, but they're typically marketed directly to consumers and through online telehealth providers. And there is a link at the bottom of this slide which talks about all the different options and also has a little widget built into this web page where you can select your location as well as the patient's insurance status to tell you what the different home testing options will be. And the types of tests that we've seen offered through home testing includes HIV, gonorrhea, chlamydia, syphilis, trichomonas for patients that have a vagina. And one thing I wanted to mention is that particularly in the case of HIV, which is for home testing typically done through dried blood spot, when it's mailed back to a lab, dried blood spot testing is excellent in terms of its sensitivity and specificity compared to lab-based testing. The oral HIV test, which is sometimes also used in these home testing kits, is not quite as sensitive as dried blood spot or lab-based testing, but at least from the HIV standpoint, the dried blood spot testing is excellent. Syphilis, dried blood spot testing is probably a little, too sensitive. You're probably going to get, some false positives there. And there's one laboratory which is offering RPR testing as well, which a patient collects blood inside a little microtainer and then is separated and the serum is tested at their laboratory. That's offered through some of the telehealth providers and including Nurex and building healthy online communities. And then of course, some companies offer throat and rectal swabs for gonorrhea and chlamydia, and some folks have also thrown in hepatitis C. So I just wanted to direct everybody because I think this page is quite useful. Kaiser Family Foundation put out this telemedicine and sexual and reproductive health synopsis, and it includes again that widget that has a finder for online providers of sexual health services, depending on what you're interested in, what the patient's insurance status is. So I recommend that everybody go to this page and check it out. I think it's quite useful.
Yeah, and then speaking of paying, do insurance companies pay for at-home testing or at-home screening test kits?
So the short answer is most of the time not. If you're giving obviously patients kits, and in the case of the Baltimore, Maryland clinic, for example, where LabCorp actually mailed kits to the house, but the patient returns it to the actual, they're getting their care still through the actual clinic, it should be covered. But these sort of direct to consumer commercial entities, usually that stuff is not covered. And one thing I wanted to mention about that is that they usually cost several hundreds of dollars, and the more organisms you test for, the higher the cost. And sometimes there's a charge just for the kits themselves and then a separate charge for the laboratory to run the test. So typically these things are not covered by HMOs, by state family planning programs, Title 10, et cetera. So it's something that is unfortunately limited to folks that have a certain amount of income to be able to cover the cost.
All right. So I do have some clinical resources, but I did just get a question that it has to do with home testing. And so I wanted to just put this out there now, and we'll move out to some more questions after the resources. But Allison Finkelbinder asks, do you have to have a home self-swab for wet prep validated? And so I would say, that's a really interesting question because validation does come up for self-swabs for GC and CT. I would say that no, you do not have to have it validated because the self-swab for a wet prep specifically is for microscopy, usually right there in the lab. But Ina, what do you think?
I mean, I don't, as far as I know, no, the places that I've heard that are doing that did not do a separate validation study to be able to do that. That being said, we do know that if somebody does go home and collect and then bring it back to the laboratory, depending on the amount of time that takes, things like trick will certainly have a tendency to die off. And so you might get a, false negative prep for trick for that reason. But my understanding is that folks that are doing this did not do separate validation studies.
Yeah, that's what I think too. Okay. That said, I think, if you are doing that method, I think that it's completely reasonable to take that into account when you're when you're putting it all together and figuring out how to treat a patient. So if if you have somebody who is describing something that syndromically would qualify as yeast and you just don't have that under the microscope, it's totally reasonable to keep that in mind that this was a self-collected thing. And so, weigh it differently when you're making your final diagnosis. All right, so all that said, there are several clinical resources available. This is our Don't Forget to Swab website that's about extragenital screening for gonorrhea and chlamydia. There's a whole toolkit. There is a national guidelines for best practices for STD management section, which is basically the CAPTC's clinical STD training services. This is what it looks like, and the website's below. And then lastly, we have the Clinical Consultation Network. And so this is a website for specific STD management questions. And so if you have any complex STDs that you, or your patients have any complex STDs, and you want to run it by this consultation line, then you can enter it at stdccn.gov, and one of our subject matter experts will answer it. Ina and I are both faculty on this, as well as many other people in California. And in terms of telehealth, for people who are transitioning to using telehealth, there's a really, really great telehealth essentials website that was made by Essential Access Health. They've collated a whole list of resources having to do with technical assistance for telehealth. And then there's also a resource, let's see if it comes up. One more resource, there it is. Oh. One more resource is the National Consortium of Telehealth Resource Centers. And so what this is it's essentially there are multiple telehealth resource centers throughout the country. And so if you go to this website, you can find the telehealth resource center that is serving your jurisdiction. There is one that is specific for California, and so they're also available to offer specific technical assistance, and you can contact them if needed.
Great.
All right.
I think I'm going to turn my camera back on if that's okay for the question.
Yeah, I want to turn mine on too. Oh, it's nice to see you again.
Yeah, nice to see you too. I'm going to answer a couple of questions that I've gotten in the chat box. And the first is not really a question, but more of a fact-checking thing from our friend Tad Tobias, who mentioned that because of funding issues, the Please Prep Me live navigation piece is now no longer funded. The website is still up, and so you can find the online clinic finder as well as the clinic finder as well as the online prep provider, content is still there, but unfortunately the live navigation is not funded anymore, which is really too bad. And then the next question that I have here is from Leo Moore, who asked about using Microsoft Teams as an acceptable platform for telehealth. And my understanding is Zoom, WebEx, Microsoft Teams, any of these that are not public facing can be used, and the sort of waiver of HIPAA or lack of enforcement of HIPAA violations that might occur because of this is still applicable. But that being said, a lot of organizations who are transitioning over to doing telehealth more formally are getting platforms that are specifically adapted for healthcare. So, for example, Zoom has a regular consumer platform, and then also they have a Zoom for healthcare product as well. So, but my understanding is that you can use any of these non-public facing video chat platforms.
Yeah, and I have one more question from Al Katz, who is probably the Al Katz in Hawaii. Hi, Al. And he wrote and I'd love your opinion on this, because I think this is something that you know a little bit more about. Your advice for preferred use doxy BID instead of azithromycin for male urethritis differs from the CDC's syndromic treatment recommendation that was provided back in April. And so he writes that you noted that there's evidence supporting doxy versus azithro because it has better cure rates for CT. And so he wants to know, should we be using doxy as opposed to azithromycin for the chlamydia patients who we see face-to-face as well? And should we be using doxy with ceftriaxone for the GC patients we see face-to-face as well?
So,
burning questions.
I know. So, Al, I can't answer this question without revealing things that are coming in the 2020 treatment guidelines, but I'll just say that the direction that we're going in is using doxycycline for all chlamydia, and the direction that we're going in for gonorrhea is really to increase the cephalosporins, and there has been increasing amount of azithromycin resistance, unfortunately, in the gonorrhea isolate surveillance project. So azithromycin is not looking so good. but I'm not making any statements about what's coming exactly, but just to say where things are going. And so that would be a mistake if our PID recommendations do not line up with the CDC's. So the PID treatment recommendations, well, there shouldn't be presumptive treatment, hopefully, of PID, right? But they should be aligned. So I apologize if there is a mismatch there, Al.
Okay. More questions. Okay.
Yes, and I have a very similar question. Can I answer one?
No, do it.
From baby with hearing, because it's really similar. Is to notice the new STD sort of treatment guidelines, especially this whole like doubling of the suffixing dose. So, should we implement those right now, or should we actually be using the 2015 guidelines? And so I would say when you're doing inpatient care, stick with the 2015 guidelines. But when you're having to do syndromic management, where you unfortunately can't, do a full exam and can't do a full workup, and you're treating presumptively, let's say for your penile urethral GC or CT, then go ahead and use the, if you can't do IM medication, go ahead and use these interim guidelines. So using suffixing 800. But if you have a person in clinic, then stick with ceftriaxone 250 plus Zithral for now. But the new guidelines, if all stars align, hopefully will be out in the next like 3 months, 2 to 3 months.
Okay. How many more questions do you have? I just got 3.
Okay, go ahead.
But I don't know if we have time for all of them, so I'll go fast. So one question is, this is a kind of general question, I think, that is it safe to do EPT if the allergy status of the partner is unknown? And so, I think that that's something that is ultimately it's up to the provider if they want to do that. That's, I think in general with EPT, you don't know the status of the partner of your patients. And so you probably, like, the best thing to do would be to explain very clearly, here is exactly what these drugs are called, here's what they are. And then if you want to counsel your patients and say, like, make sure you tell your partners these are what these drugs are. And then if the partner knows that they have an allergy, then it is, they can make an informed decision about whether or not they take that drug.
And
that's kind of, yeah.
Oh, no, sorry, go ahead, Radha.
No, that's it.
Oh, I was just going to say, when EPT was first legalized in California back in 2001 for chlamydia, there were huge concerns that there were going to be allergic reactions. And the state actually, they sent out a big Dear Colleague letter. They set up an email address and a phone number for people to call with any sort of adverse events with partners, because most of the time you're not going to know their allergy status. So we would always recommend including instructions, as you mentioned, Roz, for the person who's going to be taking the medication. Just so folks know, they had that up for 10 years and they never received any sort of reports of issues related to an adverse event for a partner. So just as an FYI.
Yeah. And then in terms of recommendation, so there's a question about recommendation of test of cure, which we didn't talk about. I think that for, in general, for test of cure is recommended for pregnant patients for gonorrhea and chlamydia about 3 to 4 weeks after they're treated. And then for syphilis, you do follow-up titers after treatment. But I don't think that test of cure is different for syndromic surveillance. I think, so there's that. And then there's one last question I have that's from Terry Anderson. Hi, Terry. That says, just to clarify, for at-home STI testing, a patient will pay out of pocket regardless of their insurance status. So I think we covered this. I don't know. Ina, do you have anything to add for that?
Sorry, a new question was coming in. Roz, can you repeat that?
Oh, yeah, of course. And I think we actually have to put a cap on the questions after this one, after Ina's answering hers. But so Terry Anderson asked that, just clarifying, for the at-home STI testing, a patient would pay out of pocket regardless of their insurance status.
Typically, yes.
Yeah.
If they're doing it at home and it's not something that your clinic has stood up as a home testing program, If it's something they're getting through one of these commercial brokers, then yes, they're almost always paying out of pocket. Although that is not true for every single one of those providers. Some of them will actually bill insurance on behalf of the patient, but some of them, many of them just require a cash payment. And then I will end it with, someone asked about if you have a PrEP patient that's adherent to therapy and they end up with an STI syndrome, why would you have to bring them in? You know, versus if they're probably unlikely to have acute HIV if they've been very adherent to PrEP. And I would agree with that. I think you could assess adherence, and if they, you know those patients are like incredibly adherent to their medication, you know they're fine, then you could do syndromic management for those folks. But I think if there's any question that acute HIV might be involved, it's probably best to bring someone in and be able to do an exam and counseling session. But we have to go. We want to stay. We can hang out with you guys.
Thank you to the 200 people who are still here with us. Thank you for sticking around an extra 5 minutes.
We are so glad that you want to hang out with us, but you have important things to do during your day, and we are so glad that you came. Thank you so much for attending. You will be getting an email about the evaluation. Give us your honest feedback. We're very happy that you guys signed on today.
Yeah, thank you so much. And if anything comes up, our email addresses are in the bottom of the screen.
Yes, they are.
Okay.
Bye, everybody.
Bye.
Bye.